Hey, everyone. My name is Bunny Ellerin, and I am the CEO of Digital Health New York. I wanted to welcome you to today's webinar, Obesity Management as a Workforce Imperative. As many of you know, we've done quite a bit of work around obesity at DHNY, and we're really excited today to have some speakers from Aon who are going to be sharing information about some studies they've done, as well as generally about the obesity arena. I am going to introduce our speakers today. We have Michael Manolakis. Michael is Senior VP within Aon's pharmacy practice. We have Tadar Penev, who's the Head of Commercial Analytics for Aon Health Solutions. And we have Cambray Roberts, who's the Health Transformation Leader within Aon's Health Solutions practice. I'm going to turn things over to Cambray, and we'll be back on when we do Q&A.
Thank you, Bunny. We're so glad to be here. As we get started today, I am joined, by two of my colleagues here at Aon. And Aon is a professional global services firm that really focuses on risk and human capital consulting for employers. And so our team that we have here today, we spend a lot of time with employers talking about health considerations for their employee population. And as many of you know, GLP-1s have been a hot topic for quite some time the last 24 months. And so today we want to share with you how we're tackling that obesity strategic conversation in the market with our clients, and share some interesting data that we continue to learn and evolve over time. So as we jump in today, I think just setting the foundation around the obesity crisis that we're facing. Many of you know, as well as employers that we're talking to on a consistent basis, where we are with 40% of the population impacted by obesity. And I think the prevalence is one thing. The comorbidity impact, just compounds the discussions that we're having in the market. And as you can see, where there's continued opportunity around, just addressing those conditions, we're often looking at things like mental health and the impact of depression, specifically around impact of obesity. We're also concerned, with where we're seeing the anticipated growth of obesity in the marketplace, as we've just continued to see a higher sedentary population, also where food and other environmental factors are contributing to that discussion. And so we want to be mindful of what we're facing in obesity, with also where is the growth of healthcare costs as they continue to rise, and also how that's impacting not just healthcare spend when we think about the healthcare plan, but also how that's impacting things like workers' compensation or other occupational cofactors that are contributing to the impact in the workplace overall. So as we move forward, one of the big discussions that we continue to have is not just the prevalence of the condition itself, but just the impact of treating the disease as we've known it in its current state, with comorbidities, in addition to those chronic conditions like cancer, diabetes, heart disease that we're continuing to see, but also just the cost of pharmacy. And I know my colleague Michael will spend quite a bit of time talking around just those impacts and cost. But as we think about the one big beautiful bill, the compounding impacts of some of those socioeconomic factors that are being considered with new populations that may be emerging in health plan considerations for employers, as well as just seeing a continued increase of 9.5%, which is what Aon is projecting for 2026. We know that a big component of that conversation has been around the cost of GLP-1 medication. And so we want to really help our employers and the market at large really think about the considerations of how do we maximize that spend, but also balance profitable bottom lines in the workplace. And so, as we continue to move forward, one thing that we've continued to discover in our conversations is what is the conversations around obesity as a condition, and obesity moving from a place of being considered a choice and really personal decisions. I think we've spent the last 20 years really emphasizing lifestyle management support and the impact of diet and exercise. But we have also discovered along the way the impact of those comorbidities, the challenges individuals facing and needing considerable support to tackle the disease in itself. And so, where we have continued to move forward is really addressing this through a lens of obesity as a disease, ensuring that we have a personalized approach, because we know that all environments can lead to different success rates, with sustainable factors around treating the disease in itself, in addition to medication and other clinical interventions. And then we're also addressing this through a holistic approach with employers and the market at large. And so, a big part of being able to unlock clinical success, we believe, is really having an engaged employee population, so that we're not only engaging them for workforce considerations, but also their dependents as we think about the impact and influence that we have on the entire household when it comes to health plan decisions. And then also just around communication and promotion, and really tackling what is very much considered, for some, a very sensitive topic, and really ensuring that we're creating an environment where we're providing support and communicating that support effectively, without being offensive or creating stigma around the disease in itself. And then really engaging leadership, both at the senior leadership level, but also creating an environment where frontline leaders are really helping support individuals through what can be a really challenging journey for sustainable work environments, especially in situations where employees may be working long hours, may have long hours in sedentary work groups, such as a call center type environment, and being really practical around how can we help support the workforce. So as we move forward, we know a big conversation right now is just how do we manage GLP-1s, whether you're deciding to cover the medication for obesity today, or whether you're already covering the medication, but you're really working to make sure that it is a best experience for the population, and ensuring that we're getting the right drug for the right reason has really generated a few different elements that we've found to be quite successful. One, as we think about managing GLP-1s and utilization management or step therapy, really considering the demographics of the population, whether we're looking at average age 30 in a population or average age 55, and then what is their work environment that may be contributing to those sustainable factors. We also continue to look at, what is the plan design and how accessible is the medication, in order to really achieve success and adherence, which I know Totter will spend quite a bit of time on later, to just ensuring that we're maintaining adherence usually creates an environment where is accessibility and affordability in that process. And then in ensuring that we're also engaging vendor partners, whether it's the health plan, your PBM, or other point solutions that you may have in place, that we're not just thinking about programs that could ultimately support a successful adherence or successful lifestyle management, but are we also creating a journey that's sustainable for the long term, and maybe just not in the time period that they're, successful through a program experience, if you will. And then as we continue to think about the member experience, does that involve technology to drive engagement and accessibility, to make sure provider access is, through asynchronous opportunities, so that we're not waiting for an appointments in environments where time is limited in the work environment? Or are we also creating face-to-face interactions for those that still really need to have a conversation about, an experience that can be really complex considering other elements that may be happening in one's life? And then the last thing we really challenge our clients with to go beyond the status quo when we think about obesity strategy is, where does the workplace policies and culture fall into place to create a successful clinical experience? Because as Michael will share, there's a lot of things that we can do in the pharmacy space, and thinking about the health plan. Totter will share the impact of making this decision for covering the medication and what type of impact we've seen in the market. But if we leave out the opportunity to really ensure those workplace supports are provided so that we can increase success for a sustainable work environment that supports the weight management journey, we're often limited on our influence and impact for the long run. And so, as we continue to move forward, I just want to give you three different areas where we're seeing vendors really lean in and support in the market today, which I'm sure many of you have been able to know, see, or maybe a vendor yourself in the experience of really supporting lifestyle management for obesity and really focusing on those behaviors that are most important for the right population. We've also seen more movement in continuing to focus on risk reduction and really driving outcomes by not just focusing on obesity in itself, but also delivering that chronic condition support where we're thinking about all the conditions and risk factors that are associated with obesity, but also starting to impact the member themselves. And then the last is really thinking about that medical model and having consistent engagement with a provider, also having prescription management review, and just really taking a more intentional effort around, where does medication intervention have the opportunity to make the greatest impact on obesity, and where there still needs to be continued lifestyle management support in order to make that successful. So with that, I am going to turn it over to my colleague, Michael, because the pharmacy piece of this, I think, is one of the most critical conversations that we tend to start with our clients.
Thank you, Brett. And good afternoon, everyone, or good morning for those that might be on the west side of the country. Michael Manolakis, and I'm going to spend a little time on pharmacy. And if we can go ahead to the first slide. This whole adventure began back in like October of 22 with a tweet, actually two tweets. Kim Kardashian tweeted and Elon Musk tweeted, and they put the word Ozempic in that tweet. And the rest is history at this point in time with Kembry mentioned costs. And we've seen plan paid pre-rebate costs over the last 2 years increase well over 100% over each year, well north of 100% over each year. And actually this year it's flattening to 30%, which is through the first 3 quarters of the year, and that's in our book of business. And again, those are plan paid pre-rebate numbers that we're looking at, PMPM numbers. So the costs have been, the increases have been astronomical. But the question is what's the pharmacy landscape today, and what are we anticipating coming? And what this particular slide shows is that the drug pipeline is very full of brand products that work in different ways, that are all coming to the market over the next few years. And that where we had a drug like Wegovy that works one way for treating obesity, and Zepbound works 2 ways for treating obesity, that we have products that are coming out that are going to work in different combinations. And in one case, in 2027, a product that's going to come out that's going to work in 3 ways. So manufacturers do what manufacturers do, researchers do what researchers do. They figure out more effective drug products. They start to change the dosing schedule. So we see that a monthly product could be coming out by 2029. They change how the drug is administered. We've been anxiously awaiting an oral form, which we believe will come perhaps by the end of this year, if not the beginning of next year. So we see a lot of changes coming, which means that competition is going to be coming, which is a good thing for price. But we also see a continued pipeline of brand products which we know are going to be expensive. If we flip to the next slide, we get a different kind of a peek. It's like, okay, so what happens with these drugs? We know there's a lot of them and there's a lot more coming. So what are these drugs doing? And we see on the one side of this screen in the gray shade, those disease states, those indications for use that are already approved by the FDA, areas where we know that these products are effective and that they've been demonstrated to be safe. And we have a lot of activity on that side. But on the research side, there is just as much, if not more, activity going on. Neurodegenerative disorders like Alzheimer's disease, and we're awaiting some reports out of those studies by the end of this year. But polycystic ovary syndrome is another. Alcohol consumption and tobacco use disorders. Again, dependence disorders are being studied. And we know that these GLP-1s work to make you feel fuller, that we know that they have a positive effect on blood sugar, but they're also doing something else in the body. It's speculated that it has to do with reducing inflammation, but something else happens in the body, and there are dozens of studies that are going on right now across a variety of different indications, hundreds of studies actually across dozens of indications that are potential indications for use. So lots of chapters yet to be written. But if we go to the next slide, what's really interesting right now, and Todder's going to get into this because what his team has been able to do is start to look at, well, what's actually happening? And that's in my world in pharmacy and with physicians and nurses and other clinicians, we say, what's the real world evidence? Outside of the trial, what's really happening? And the things that we've learned, that we now have 2 years, almost a little bit more than 2 years, to look back and say, these drugs are effective. The health benefits are significant. We know that now. We speculated on that 2 years ago, but we also worried a lot about safety 2 years ago. We're not really thinking that much about safety anymore because the real world evidence is so strong. So what we've learned is that supportive lifestyle changes are critically important to success. And Kembre mentioned that holistic approach, and I can't drive that point home enough, that you can't just give somebody a drug and expect it's going to happen, because for them to persist on therapy, they need support. And finally, we're starting to see more uses and support for more uses. These were the SELECT trials, one of the original manufacturer-sponsored trials, and we see out of those trials additional research happening. One, kidney outcomes are very positive, but one that was it was recently published in the Lancet, which is kind of fascinating because, and it gets to that point that, yeah, this has something to do with weight loss, but there's also something else going on. And out of this one particular study, as the researchers went back and explored the data, they realized that there was a connection with losing fat, adiposity, but there was also a cardioprotective effect, something positive to the heart that couldn't be fully explained by weight loss alone. So that opens up the door to that idea that something else is happening here. So lots going on in the pharmacy space. Costs continue to climb. Real world evidence is interesting. And on that note, let me turn it over to Todder to explain what Aon is doing in that space. Todder?
Thanks, Michael. And it's a pleasure to see everybody. Many familiar names on the attendee list today. And so what I'll do over the next few minutes is walk you through a deep dive research project that we commissioned internally at Aon, really trying to do exactly what Michael was saying. This is what I would describe as, stage 4 trial. Let's look at real world data. We're very focused specifically on the workforce and the impact on the workforce and human capital at Aon. So we're interested in working adults and what these drugs potentially could do, not just in terms of costs, which is fairly easy for the accountants to kind of tabulate, but much more importantly for the population health and the trajectory of healthcare spend more broadly. As Michael mentioned, one of the fundamental principles we adopted here was not to strictly look at diabetes or weight loss or any one kind of single condition, but we are looking at workers. We're looking at adults that are covered by employee benefit plans, and we actually look at everything that they do throughout the year. And actually, as you're going to see in a second, throughout 3 kind of multiple longitudinal studies across 3 different years. So all pharmacy spend, all medical utilization, and we're also working, which we hope to come out in coming months on expanding actually that work to looking at disability, incidence of sick days, workers' compensation, and other correlated factors in the study. GLP-1s really are changing the insurance industry dramatically, even beyond medical and pharmacy. So you're looking at life insurance impact, for example, underwriting impact for life insurance and how people are underwritten. You're looking at longevity impact, potentially mortality tables, and thinking about kind of retirement investment planning. So we're just at the beginning of seeing these impacts in the data, understanding these impacts, and we're committed as an organization to kind of measure, report, and help organizations navigate that emerging ecosystem. So let's go to the next page and talk a little bit about kind of some of the challenge. And so if you look at the clinical data, right, and all the randomized control trials, all the emerging clinical literature, there's so much to be excited about. There's, reductions in cardiovascular, improvements in mental health. We're starting to see these numbers. If you put your plan sponsor hat on or an insurance company hat on, though, the costs are very high. And as one very large insurance company says, the costs are guaranteed, the benefits are uncertain, right? In this case, and so it's really been a tremendous challenge, especially for the employer market, where each employer kind of makes their own decisions with respect to, benefit richness and how much to cover and how much not to cover. And as you can see, this is a Aon survey data it's about a year old, and we're actually in the process of refreshing this, and the numbers are pretty much the same this year. But you see this kind of 50-50 split in the market of organizations that have said, okay, we're only going to limit to diabetes, right? Versus organizations that have said, okay, we'll actually expand coverage for weight loss more broadly. And as you can imagine, this list goes on and on into kind of, do we, expand coverage for cardiovascular disease, for sleep apnea, et cetera. And it's, in fact, we've worked with a number of very large organizations in the country that have actually flip-flopped on this question, throughout the last 2-3 years. They started by covering, they saw the bills coming in, and what that was doing to their increases in their budgets. They stopped or significantly, pump the brakes on, the coverage, or put, prior authorizations and other requirements in place. And then the demand's been, increasing, as we're going to talk about in a second. Perhaps the pricing is actually improving, or at least we're getting more clarity on the pricing. And actually, they've reconsidering adding coverage back in, right? And this is happening a lot in the market, right? We tend to work with larger, more enterprise, large private and public sector organizations. But certainly the market's been very split on this topic, and those focused on costs have been more conservative. Those focused on health improvement have certainly paid a pretty significant cost, especially in the first years, but hopefully start to see some of the benefits. And this is really the reason we started to invest in kind of answering this question. So it was really, really hard to kind of be a consultant and help these organizations navigate the landscape when, we can't fully reconcile the amazing clinical benefits with kind of the total cost picture over the last couple of years. And so let's go to the next slide and how we approach this in Aon. And so we assembled data on over 50 million commercial lives in the market. So think of these as large self-insured plan sponsors where we have linked medical data, eligibility data, and pharmacy data. It's actually, the data comes from multiple different data sources, but the commonality is they're all commercially insured. So this is not Medicare, Medicaid lives. We have longitudinal data, so we could trace them across multiple years of data, and we can analyze each member holistically. So not just, one condition or one type of spend, but we could look at what happens to them kind of throughout the healthcare ecosystem. The results I'm going to share with you were published in May. And we're actually refreshing these results, and we already have 6 months more data compared to those earlier results in May. You can see you're actually going to start seeing more and more updates to this time series come out from Aon. And again, we're just in the early innings of what I would argue is going to be with us for a topic that is going to be with us for a couple of decades probably. And so as more data emerges, as more of these newer drugs that Michael was talking about come to market, as more FDA indications are being approved, we're going to see actually this time series evolve over time as well. And so this is really, really important to kind of keep thinking and keep looking at the data and adjusting strategy and our understanding of the space as we learn more about the space. The fundamental methods we use for this analysis are basically a match control method. We actually have specifically tailored this for commercial employer insurance use cases. This is a method that Aon's developed in-house, but it pays a lot of attention to factors like geography, for example, which is typically kind of ignored, especially for pharmacy type analyses. And so we pay a lot of attention to demographic, geographic patterns, and we make sure when we look at the patients taking the drug that we compare them. We develop this counterfactual group that looks exactly like them, matched right even to the zip code effectively. And we trace that matched cohort over time to see kind of how the group that's taking the treatment differs from the group that is not taking a treatment. Again, kind of the, in pharmacy speak, this would be probably similar to a stage 4 trial. So we're emulating a randomized control trial, but of course it's observational employer data, so we can't fully randomize, who gets what. We're independent as an organization, right? So this is not funded by any kind of health plan or pharma or anybody else out there. And we're doing this again because we get these questions as consultants from pretty much all of our clients all the time. And we're, as I mentioned, we're just in the beginning of this. So really, we think of this as a multi-year landscape that we need to look at. So not just a snapshot answer, and you're going to see kind of the early results, but we see this as a moving in rapidly evolving marketplace that we need to kind of continue, refresh, and work on. And so you're going to see more of these results come out, and potentially even going beyond the medical and pharmacy results into disability, kind of broader human capital impact, and quantifying the broader economic impact. So let's go and dive into some of the results on the next slide. And so I'll start with the costs, right? And I'm a health actuary, and so this is the number one question people struggle with, and we see a huge challenge in the market on. And when we compare people who start taking a GLP-1 treatment, and again, the way that we're comparing them is in this timeline. It shows you, a little over 2 years based on when each patient started the treatment. Right. So this is actually if you're thinking insurance, this is very different, because insurance is what do we do this quarter? What do we do this calendar year? What's the premium for next year? This is now based on when the patient started therapy. And as Michael said, we really started seeing a surge in utilization kind of late 22 into 23. And those people who started in 23, we can now follow them for 2 years because we have data through, middle of this year. And so actually we could follow what happened. If they started therapy in 23, 24 was their first year, 25 is now their second year. So we could kind of follow them longitudinally. As a reminder, 23 actually, Zepbound was not approved yet, right? So these were kind of the early days of, a lot of utilization. So these people we have a lot of durational data, they were mostly still on, Ozempic or Mounjaro. And a little bit of Wegovy, but actually as we move forward into people that are starting on this therapy now, actually we see a lot more of the kind of weight loss indications of Bound and so on, and you're going to see this as we refresh the data and the results as well. Although, and I will spoil the surprise a little bit, the trends are very consistent, right, and remain very consistent, even though we see people starting their therapy for a very different potentially indication, and from a different starting point, patterns are holding up very well. So again, think of this as like 20 people that started therapy in 23 that we followed for 2 years. The bottom line, the control group, these are the folks that, they started exactly the same. If you see all the way on the left, they basically cost about the same. Importantly, if you look at this, PMPM, per member per month cost, $800 per member per month is actually fairly high, right? So these folks their starting point is not one of, they're very healthy. Their starting point is this group is probably late 40s, has, a few chronic conditions or emerging chronic conditions, if not, fully diagnosed diabetes, and then trending pretty high. Right. And they're not getting any healthier. And they're, if they started at age 48, they're now 49, they're now 50, 51. So this is a cohort that is already kind of on a trajectory, with their health and their cost that's kind of increasing. You could see this in the orange line, even before we introduce a treatment in here. If we step up and look at the blue line in the middle, this is the people that actually started taking the drug, right? They started in the same place, but the only difference is one of the groups started a therapy, and you could see actually their costs go up, right? And the middle line shows you the cost without including the injectable. And so even without excluding the cost of the drug itself, their costs went up. They actually had more office visits in the first year. They have more lab work in the first year. And you see this kind of bump, right? This when they start a therapy. You can imagine what's happening here, right? Some of that could be just side effects, and they have more lab work. They're more, especially in the first few months of treatment. Some of this, I would argue, probably kind of self-inflicted, frankly, by the insurance plan design, because we make people jump through hoops and prior authorizations and step therapies and all sorts of things, right, to get to the treatment. And so actually you see a lot of people that have not really seen the doctor, had lab work done in many months, and all of a sudden they show up at the endocrinologist, right, and they get a bunch of lab work done to get to the treatment, right? And so actually their medical costs are also going up, not just their pharmacy costs. And so that's kind of what the first year looks like, right? We see that cost going up. I think that's kind of been well documented by a number, insurance companies and so on. And where we get more excited is if you follow that line, between the first and now the second year, we actually see this significant slowdown, and almost like the line is flattening. And this is the proverbial, bending of the cost curve that I think many of us that have been working in this space for a long time have been looking for, for in terms of, weight management and obesity reduction. You would expect to see, a change in the long-term trend in the health trajectory of a person. And I'll say this chart shows us just the very beginnings potentially of that, right? And I wish I had 5 years of data to show. It's only 2 years, but you could see that second year, the people that weren't taking the therapy continue to trend on fairly steeply, right? And just as a reminder, what Camber shared at the beginning, we're kind of in a very high trend environment. So we have a lot of 9, 10-digit trends, even 11, 12-digit trends. So these people are continuing to actually get more and more expensive. The folks that started the therapy, they had this bump in the first year, but actually then slowed down significantly. Right. And again, we're really interested to kind of expand this time series with, 6 months more data and another year of data. And if that trend holds and you see that sustained slowdown in growth, that is going to be extremely powerful, right, for the overall kind of healthcare impact of the population. And the reason for that, by the way, is we're starting to see in that second year a lot less inpatient visits, right? And we're starting to see kind of the acute care episodes decreasing, and we're looking, and interested to see kind of how the mix of utilization changes. And I'll show you a chart on that in a second. Just before we move, I want to acknowledge maybe the top line. That's the one that starts to include the drug cost, right? And as you know, the medication list prices are probably in the 4-digit range, right? So $1,200, $1,300 list price. The effective prices are a little bit of an enigma. We've made an assumption here about rebatability, that these drugs are roughly 35, 40% rebatable. They're actually probably even higher than 50 in some cases. And I'm sure you all, following the headlines in Wall Street Journal about the direct to consumer, what's happening with Trump Rx. You could buy, Wegovy now at Costco for $4.99. But if you look at that top line, including the drug cost, obviously the people that are taking drug quite a bit more expensive right away. But actually, once they're on the therapy and you start following them into their second, third, and so on years, actually their costs are really even further flatlined. And that's because, potentially people after that initial year, if they reach their clinical targets, potentially drop off, right? Some of them may drop off for other reasons. But potentially the cost of the drugs actually could be improving through competition and et cetera. And so we're optimistic even the total cost picture, which is still a big challenge, will end up over multiple years actually looking at cost effective for a number of different plan sponsors. So let's go to the next slide and get into a couple of the more kind of detailed clinical results. And so this result shows that decrease in inpatient admissions that I mentioned. The MACE, or the major adverse cardiovascular events, so think heart attack, stroke, heart failure. These are hospital admissions, and all we're doing here is counting hospital admissions. What happened for the group that started on the GLP-1 therapy and what happened for the group that never started, or at least not that we can tell from an insurance perspective, never started the therapy. And you can see we're finding roughly a 40%, a little over 40% decrease in hospitalizations. These are really, really powerful results. It's, by the way, it's been validated with randomized clinical trials as well. This was part of the FDA approval for Wegovy, is a cardiovascular drug as well. And we were super excited to actually find this in the data for working adults as well, because the randomized clinical trials, they were 62-year-old males on average, right? That's what went to the FDA. This group, again, they're 48. They're actually more heavily female. In fact, we're finding that the female reduction in hazard ratio is actually stronger than the male reduction in hazard ratios in here, right? So these are working adults, and that's kind of what a typical employer workforce looks like. And we see the result that's super, super powerful. Why is this not in the impacting the cost? Well, if you look at on the left and on the vertical bar, this is still a very rare event, right? So we're talking over 150,000 members in this sample. We saw a reduction of a couple hundred events, so for any one employer, unless you're a very, very, very large employer, you may only have one or two of these types of, heart attack events, reductions. But this is so powerful from a human capital perspective, workforce perspective. And I don't need to tell you that not only is, these events very expensive from a healthcare system perspective, but they cause tons of disability, productivity loss, and impact well beyond just the hospital bills and these events. And so really powerful result. We're also tracking results that are not approved FDA indications. So for example, Cambry mentioned mental health, and we're seeing very significant reductions in actually admissions for substance use, or alcohol substance use, even for respiratory conditions as well, right? So we see this impact across the healthcare state of the member, even outside of the approved FDA indications. And let's go to the next slide. If you look at just a mixture of different incidents of different types of conditions. And again, we're measuring healthcare claims here, right? So we have to be mindful. Basically, what this means is somebody went to the doctor or showed up right at a healthcare setting with this type of diagnosis, and we're looking at incidence effectively. So do we see the people that are taking the drug go up in incidence or go down in incidence? And we're actually seeing several reductions, right? We see these respiratory conditions, IBD, IBS. These are really, really powerful reductions, and just very debilitating diseases as well. So not just expensive to treat, but potentially causing a lot of absence and disability in the workforce. We already talked about alcohol substance use disorder, significant reductions there, stroke, right, cerebrovascular disease. Interestingly, and perhaps this explains why the costs have been so stubborn, right? And why if these drugs are so wonderful, and why are the costs not just falling off a cliff? Well, we actually see some things increasing as well, right? And so you see certain types of musculoskeletal disc joint disorder utilization actually increasing. You see thyroid disorders increasing. That's actually a well-documented side effect. We also see kind of sleep-wake disorders, maybe a couple other things that we're tracing through the data also increasing. And some of this is probably side effects. Some of this, I would argue, maybe more. And if you speak with clinicians, right, who work in the space, if you think about a patient who potentially lost 20-25% of their weight, now they're in a much better place, but now they're going to take care of their knees, for example, or potentially previously they were ineligible for a given procedure because of their weight, or it was too risky, right, to kind of operate on them or have a knee or joint replacement. Now they lost the weight, so now all of a sudden they're getting their knees done, right, or they're getting their hips done, and so you actually see a lot of these kind of what I would argue potentially is bounce back utilization. It's a sign health is improving. So this is good from a population health perspective, but it's also from a cost perspective, right? It keeps the costs very stubbornly high for these members. As you can imagine, we're very, very interested in how this plays out. More, this is just 2 years of data, how this plays out over 3, 4, 5 years of data. And, in theory, that should, if you see this bounce back utilization, potentially there should be another leg down after that, right? And kind of in these members being a little bit healthier. Michael, I think, already gave a shout out to the Nature study that was published this year. I'll give a big shout out to that paper. Our results that we see with employer data is actually very similar And that was data for the VA, right? So the Veterans Affairs Administration, which actually has excellent, both insurance data as a payer, but also clinical EMR data integrated. And actually, they likewise saw a whole bunch of reductions, but also several increases that are kind of in incidence and utilization. And these are really important to understand. So to recap, if we go to the next slide, what we're looking at is, a multi-year impact of these drugs, right? And we're just now starting to see, especially for those patients that started the drugs and have been on the drug for a couple of years, we're just now starting to see those impacts. And actually, nobody has been on Zepbound for 2 years yet in the market, right? That drug was approved late November 23. So actually the people that are, the first people that were officially on outside of clinical trials are just now kind of completing their 24 months, basically. And so we're just in the very beginning of kind of seeing that, multi-year cost trend emerge. We are super excited to see these reductions kind of in adverse events, especially, cardiovascular, but also, mental health, and others, and we see a very, very broad impact across the health of the individual, right? So not just limited to the approved indications, but several things improving, several things potentially kind of bouncing back or seeing increased utilization. A couple of things we're actively researching, and you hopefully will be published in coming months. We're particularly interested in women's health impact, right? So we're starting to see a lot of off-label use in gynecology clinics, especially kind of women of kind of menopause age. And you see as many as 20-30% potential utilization in some cases. And we actually are starting to see in our data reductions in certain incidents of certain cancers, or conditions like PCOS, for example, that these are not approved, right? This is kind of off-label use effectively. But you clearly highly correlated, right, with weight reduction and kind of weight loss and some of the impact of the drugs. We're also very interested in kind of mental health and just broader implications. And so a lot more to come on this topic as we get more data, more research, but these are kind of our early findings. And you could find, the white paper, the methodology in detail on aon.com, or happy to send it to any of you on the line as well, and with more detail. And so maybe to kind of wrap on a couple big kind of just very common questions we get on this topic. So number one, if we go to the next slide, just what about adherence, right? And this is very commonly what we hear from, actually we're hearing a lot of that in the 22, 23. Oh, benefits are amazing, but people don't stay on the drug long enough, right, to really see the clinical benefits, or, what does adherence look like? And they were right. I mean, actually 22, 23, if you look at adherence rates, and these are, measured kind of by the textbook definition of adherence, which is people that, fill the drug more than 80% of the time. And what percentage of the people that started therapy are kind of hitting that, benchmark of adherence. And you see in 22, 23, half, maybe less than half for weight loss indication were actually there. Now the number's been improving, right? And actually our early kind of 2025 data shows, even more steady improvement. And you can imagine some of the dynamics that were happening here. So 22, 23, there were actually drug shortages. A lot of plans were, again, kind of stop and go a little bit, or figuring out, benefits and access. I would argue, to Michael's point, those tweets and just if you think of what was happening, the New York Times had an article that I think started with vitamin O for Ozempic, right? And so there was a lot of, I would argue, kind of naive utilization in 22, 23. So people that kind of got onto the therapy because that was the popular thing to do. And I think some of that's probably played itself out, right? That you now see the people that are starting now actually kind of, it looks maybe a little bit lower for weight loss in terms of adherence. But actually starting to approximate kind of a more typical, diabetes treatment or cardiovascular treatment. But certainly and we're going to be publishing this result here in the coming weeks and months. People that are highly adherent, as you can imagine, reap the most benefit, right, from the therapy, right? And people that are just kind of poorly adherent or less than 50% adherent actually kind of see a very muddled result, or not as much. And so so the results I've been sharing in the last 3 slides are kind of everybody all in, basically, at least those that sustained the therapy for a while. But if you focus on the people that are highly adherent, the results are quite a bit stronger as well. So this is really important. And as you can imagine, this is a digital health audience, there's a lot of work to be done, right, to make sure these treatments are that we support the patient, that we don't kind of waste the drug. The wastage would be somebody that kind of takes it for a few months and then just, stops taking it. And that was a waste of, and then just regains all the weight. Right. And so there's a ton of innovation, I think, in the space that we're really excited about. And I'll end on just a slide with cost, and just, I can't, it's hard to avoid this given all the headlines. Just even in the last 24 hours, one of these on the right side, these are all Wall Street Journal headlines, the price wars that are happening, what's happening kind of with, formularies, the 149, that was the breaking news yesterday, right, for potentially for Trump RX, and potentially with an accelerated, path to FDA approval for the oral version for Eli Lilly. It's been really, really hard to see clearly in the space, right? Because pharmacy pricing is very non-transparent. This data comes from ICER, which in turn kind of pulls from a number of different data sources. But you could see in red on the left are the list prices, right? And so if you have a high deductible healthcare plan and just walk into a pharmacy, many times that's the price you're going to see hit your deductible, is kind of that red price. The net prices are actually the prices kind of after rebates, right? And these are estimated. We don't know exactly what they are, and so they're estimated through a bunch of different data sources. But you could see the prices are probably quite a bit lower. And again, you could, even the direct to consumer pricing is, we mentioned $4.99 at Costco, right? Or, $149 at Trump RX for potentially lower dosage and so on. It have really created kind of a lot of uncertainty, especially for plan sponsors that are trying to kind of say, okay, is it, I would argue a lot of plan sponsors will be perfectly comfortable covering this drug at, like, say, $200, or $150. They may not be comfortable with $1,200. And there's a big range between these two numbers. And so that's another one to kind of keep an eye out on. As Michael mentioned, there's a lot of competition. We have two big manufacturers now, potentially a third one coming in, Amgen by 2027. But even between those manufacturers, we're starting to see competition on, the form. Is it an oral? Is it an injectable? Right. And kind of what is the, is it a vial or a syringe, and so on. And so there's, quite a bit of that potentially is going to be changing for us as well. So let's wrap. And I know there's quite a few questions I can see popping in the chat, so I would love to get to that. And maybe just to recap, kind of where, as consultants, right, to a lot of plan sponsors and employers, really are kind of three-step action recommendations have been: first, start with a holistic strategy on obesity, right? So don't treat this as just a reactionary, hey, do we cover this drug, not cover, what do we do about this new class of drugs? This can be potentially the most powerful tool in a bigger, strategy that supports the member, provides support well beyond just the pharmacy coverage. And that's kind of what Cambry and team spend a lot of time on. Balancing the economics is really challenging, right? And so how do we cover, but how do we cover responsibly, especially given that we're in very high trends, right? And potentially, unlocking coverage. And I work with one client that went from about 10 million a month of spending on these drugs to, like, roughly 50 million a month in a matter of 6 months, right? And they're so popular, right? And if you kind of let it rip, the uptake is really significant. And so how do you do this, right? And there's a lot of tools, in between kind of covering and not covering, and how to cover responsibly. And last but not least, measure and understand the impact. And we're just at the beginning of learning about, what happens and where this is going to go. And so I think a lot of people kind of looked at data from 22 and 23 and came to a conclusion. I would challenge them to kind of look again, right? Because we see, not just the landscape is changing, the prices are changing, but also the types of adherence and utilization is also changing. So as the market matures and the market settles, we're going to be in a very different environment here. So, and we're committed to keeping you all updated. And so look out for more information. And again, for those looking to learn more, you could find the full research white paper on aon.com, and happy to answer any questions.
Wow, that was phenomenal, the three of you. Wow, and a lot of research has been done. So yeah, we do have a lot of questions, and why don't we start with this one, which I like a lot. So given that we've just talked all about coverage, what does Aon do for its own employees, and do you cover GLP-1s?
Yeah, I'm happy to take this question. So we have the fortunate ability to today offer obesity GLP-1 coverage for those that are enrolled in our health plan. And that is available to employees and their dependents. There's also an incentive if you are using the obesity GLP-1 coverage through our preferred vendor, which is EatMed. And those individuals also get a discount for using in their health plan in order to use that service to really focus on adherence and have that continued experience today. We also support lifestyle management behavior in that process with our Thrive Global as our well-being vendor. And so we have done an integration between EMED and Thrive Global in order to have that seamless experience of getting that provider support, adherence support, and then also have the ability to have that lifestyle management coaching and support and additional factors just to provide that holistic, well-rounded strategy as well. And Bunny, what's been fantastic about the approach that we've taken is we've really encouraged our employees and their family members to really focus on adherence so that there is long-term. And so they do weekly check-ins. We have 95% compliance today, with that impact. And we're also happy to share other results that we're seeing in supporting our colleagues at Aon as well.
That's impressive, 95%. Very impressive. Well, staying on coverage, we have a bunch of questions. One is, does the analysis incorporate expected employee retention or turnover rates?
Yeah, great question. So these are people we observed, right, for 2-3 years. So there's kind of an implicit retention in there. This is not Aon research, but it was published, by another actuarial firm. There's actually research that suggests people stay longer with an employer, right? When they're especially there's a correlation there, right? And they're obviously on a treatment, potentially losing weight. So we see this as a full human capital picture. The results I shared are mostly focused on the medical plan, but we believe that we're going to start seeing those impacts as well on kind of disability rate, retention rates, and hopefully keeping people healthier for longer is going to make a big impact. I would say industries that tend to retain their employers for a long time. So think like utilities, public sector, they're the ones where we see the biggest impacts and the biggest as well, right? As opposed to the ones that are kind of have a high turnover population. Yeah.
In one of the slides, you talked, in several around mental health, and one of our listeners was curious as to your perspective on why mental health disorders increase.
Yeah, so we're seeing, and it was certain types of mental health disorders and also potentially sleep-wake disorders. Yeah, we're unsure. I mean, I think that field is emerging. We see a reduction in actually acute mental health. So, for example, admissions with mental health are actually decreasing significantly. These are, substance abuse, psychosis, and so on. There's a big decrease there, but actually you see some more outpatient utilization, like potentially for these members. Again, some of that could be, just correlation, right, with the drug. Some of this is like these members are now kind of engaged with the system, right? And I think that's a kind of a behavior effect happening here. So there's, for the longest time, right, they had a condition, potentially was untreated because there was no good treatment available. All of a sudden there's a treatment, and actually the treatment works well. So now they're actually engaging in the health system more, right? And they're seeking therapy. They potentially kind of show up at the doctor and have more frequent check-ins. And that, as Cambry mentioned, mental health support is a key part of any kind of support program as well. And so I think some of that could be explained by just the behavior shift that happens as well.
One comment. Yeah, Bunny, one comment that I might add is we just think about employee well-being focus groups that we're doing and just the impact on weight management and changes. While we know that we have the clinical rigor through our data analytics, we also know from experiential studies that we're doing just on sentiment in general, when there is significant weight loss, there's also friendship changes, relationship changes, the dynamics and experience of that individual change in their overall work and life, which can lead to conversations with their physician around different expectations around anxiety, or just needing therapy support to undergo that. And then also where we continue to see body dysmorphia even after losing 100 pounds. And so while we don't know the exact causation in what Daughter has alluded to, I think we're also very mindful of what we're seeing in qualitative data just around the experiences of a significant weight loss and just the impact on relationships overall.
A similar line of thought. Somebody asked about more increased conditions like osteoarthritis and joint disorders. Is that the same answer, which is now people are engaging with the health system, so they're uncovering it? Or is there another reason?
So that one gets a little tricky. With most of the indications that we have today, we're dealing with that same population, population that has the disease of obesity or overweight. There's direct correlations with sleep apnea, as well as our liver conditions. As we start to broaden it, it's going to shift a bit. Kembre, do you have any thoughts on that question, just as you heard it?
I mean, I think we're speculating, right, on just what we know about member experience and how that's changing. I think just as Totter had acknowledged earlier, just where we're seeing individuals be able to qualify for musculoskeletal treatment that they might have not done before. I think what we're also seeing is just more movement in general, and where we're seeing some additional injuries where it's maybe things were uncomfortable before, but we're also seeing the willingness to go and get that provider care where maybe before I was just hesitant to make that visit or to even know that maybe I had a herniated or bulging disc or something to that effect. So I think we have more work to do that Totter's alluded to just continue our studies and complement that with qualitative experiences that we're learning in focus groups when we do well-being focus groups with our employer populations along the way.
We have time for one more question. Given that orals are on the way, where do you see, or this is sort of a guess, but where do you see prices going and the economics going?
This is a crystal ball question because
Yeah, exactly.
We won't know until we know. But if I'm going to speculate for a second, I would anticipate the cost would be lower because we don't have the cost of the device. So that and we're dealing with small molecules, not big molecules that are hard to make. So we would expect it to come down, but time will tell. Price compression, as Totter mentioned, is rapidly happening right now in the space. But we've still got a long way to go because the prevalence numbers are so high, which of course puts that pressure on the budget for our employers that are out there.
I would say, 10 years from now, we're probably going to look back at these last 3 years as kind of the dark ages of GLP-1s, right? And this has been the pattern with, new blockbuster novel treatments. And we've seen that play out with, other drug classes as well, where we're kind of in the upswing. We're going to reach potentially saturation point, right, as well in the market. You have competition, and eventually these drugs, are going to go generic in the 1930s, and hopefully it could be very cheap to manufacture. Now, in the meantime, for the next 10 years, we have some challenging math to do, right, in terms of kind of the healthcare economics and the cost and benefit trade-offs. And so we're, hopeful about the data that's emerging is gonna help, as well as the competition, that Michael's referencing are going to kind of help balance that. But there's no question in my mind, right, that 10, 15 years from now, these drugs are going to be cheaper for a variety of reasons, including the expiration of the patents, but also they're going to be widely utilized. And we've seen that kind of play out with other drug classes as well. Yep.
With that, I want to thank Michael, Totter, and Kembre for an incredible presentation and information on obesity. And thank all of our listeners for tuning in. As we said before, there's a lot of data on Aon's website, and we will also try and share that in our follow-up. So thank you so much and have a great rest of the day.